On this edition of Veterans Health Watch, we'll talk to experts about the diagnosis and treatment options available for veterans managing arthritis, osteoporosis, and osteoarthritis. Welcome to Veterans Health Watch, a program sponsored by the Veterans Affairs Maryland Healthcare System that provides the latest health and benefits information for Maryland's veterans, their family members, and the local community. I'm Kenya Griffin. According to the Arthritis Foundation, 1 out of every 5 adults in the U.S. is diagnosed with arthritis, making it the leading cause of disability in America. And joining us to give us a better perspective on this disease is Dr. Amit Golding. He is a VA rheumatologist and a recipient of the VA Career Development Award for research. Dr. Golding, thank you so much for joining us.
Thank you.
So let's start with a discussion or description of arthritis. What does it look like in the body of someone who has this disease?
Well, itis basically means inflammation. Arthritis occurs when you have inflammation in the joints. People get pain in their joints, swelling in their joints. They're very uncomfortable and very stiff, and it really affects their ability to function.
Are there different types of arthritis? We hear people complain about, the pain in the knee. Is it something different than maybe a pain in the elbow?
Sure. There are 3 very common types of arthritis in the United States. Many people have probably heard of osteoarthritis, which is more of a wear and tear arthritis associated with aging or overuse. There are a number of forms of more autoimmune arthritis, and one of the more common ones that people may have heard of is rheumatoid arthritis. Another one that affects many people that is more related to diet is called gout, where you have a very red, hot, swollen, like big toe is the classic example of that. So those are a different variety of arthritis.
I didn't know gout was a version of arthritis.
Yes.
And so I'm sure the symptoms are different for these different types of arthritis. Can you describe some of the symptoms for the different types?
Absolutely. So osteoarthritis, and Dr. Hochberg is going to be with us a little bit later, is going to go in more detail, often affects the weight-bearing joints, the hips and the knees, and can affect the hands, things that you use a lot. Rheumatoid arthritis can be similar, but will affect a lot of the joints that may be not necessarily from overuse, it's just being attacked. And both sides are often affected in a symmetric way in rheumatoid arthritis. And if left untreated, unfortunately, it can cause permanent damage to those joints. Gout is a little bit different. Gout can be kind of an attack that can come on almost overnight in just one joint or a few joints like the big toe. It can happen all over the body, but that's kind of the classic example.
So are there any exposures, environmental issues that contribute or cause arthritis?
So that's a very important question. There is definitely evidence that certain factors in the diet, especially for conditions like gout, but even for osteoarthritis and rheumatoid arthritis as well, the diet can have an effect, as well as exposure to toxins in the environment. And certain habits that in general people should try to avoid can also make arthritis worse, such as smoking.
Okay. And in addition to smoking, what other habits can contribute to this inflammation?
Well, some people have looked at the role of obesity, and definitely that plays a very important role in osteoarthritis and wear and tear. But there are a lot of unanswered questions that we're interested in trying to find out more.
Is arthritis hereditary?
That's also a very interesting question. So sometimes we see that it seems to run in families. Someone will come to us with, let's say, rheumatoid arthritis, and we ask them, and it turns out their mother had it or another sibling has it. And people have done very large studies to look at whether there's certain parts of our genetic code that increase our risk of getting, let's say, rheumatoid arthritis, and there are some hints to that.
Okay.
Absolutely.
And what about the difference between, or the prevalence in the women versus men?
So that's also very interesting. So some of the conditions seem to equally affect men and women. So osteoarthritis seems to be pretty much equal, although it may affect women and men in a different way, but the incidence is similar. Gout tends to affect men more than women, but it does happen in women. Rheumatoid arthritis is a little bit more prevalent in women, but almost equal. But there are some conditions that people may have heard of that are also autoimmune conditions, such as lupus. That definitely affects women more than men. And then there are other conditions like psoriasis and psoriatic arthritis that affect men more than women. So it's important to recognize those differences, and we see a diverse, group of patients in the VA.
Yeah, I always remember seeing my older grandmother, great-grandmother with the big knuckles, and she would complain of the pain in her hands from arthritis.
Right.
More than I would remember my grandfather noticing it. Okay. And so how is arthritis diagnosed, and then how you treat it?
So the diagnosis of arthritis is really based on a combination of the clinician, the physician, usually the primary care physician first, and then the specialist, recognizing the clinical signs and symptoms. When the patient says, I have stiff joints in the morning, they get a little bit better during the day, my knuckles on both hands are stiff, swollen, red, then there are some patterns that we learn to recognize. And then we, of course, meet the patient, examine them, feel the joints for tenderness and swelling. And there are some important lab tests. Each condition seems to have its own set of lab tests that can help us with the diagnosis.
And when I asked you a few questions, you mentioned that those questions were interesting, and you're learning more. What types of research are you doing in the VA in regards to arthritis?
So people should know that in general the VA is very supportive of trying to do research to improve the health care of veterans. And the research in arthritis kind of runs the gamut. So there are some people trying to understand more about the environmental factors, like you asked me about, maybe some of the gender differences, maybe even factors that we could do to prevent or treat even without medications. And then the work that I do is more focused on trying to understand the basic mechanisms of different types of arthritis and autoimmune diseases in the lab.
And you mentioned you see the gamut with the veteran population. When would you recommend a person come in to see a doctor? If they're at home and they're experiencing a little tightness here or there, maybe they're a gardener or pretty active, when do you say, okay, it's time to go see a doctor?
I think the key question that everybody has to ask themselves with anything medically really is this preventing me from doing what I want to do? So if I can't go to work, if I can't take care of my children, if I can't wash the dishes because my hands are hurting me too much, we call these activities of daily living. At that point, when it's affecting your life, you definitely should seek medical attention.
Dr. Golding, thank you so much for sharing this great information about arthritis. Is there anything else you would like to share with our veterans about this disease?
Yes, and you're very welcome, of course. I just want to re-emphasize that there's a lot that veterans can do to take care of themselves even when they have one of these diagnoses. So obviously we partner with them, we can give them medications, but all the things that they do to maintain a healthy lifestyle, including avoidance of alcohol and smoking, will help their body in general and also their arthritis.
And thank you again. We're going to take a short break, but when we return, we'll have more about osteoporosis and how it affects a veteran's health, so please stay tuned.
Did you know that Department of Veterans Affairs provides physical and mental health care for over 8 million veterans? Hi, I'm Natalie Dell. I may be an Olympic medal winner, but I know that real champions are those who have served this country, and VA knows that too. As a VA employee, I've seen the challenges our veterans face. I'm honored to be part of a team that supports veterans in achieving fuller, richer lives, and I invite you to join us in this rewarding experience. If you're a mental health provider, I urge you to visit vacareers.va.gov.
The VA Maryland healthcare system
We would like to recognize and thank Maryland veterans
who fought to protect freedom and democracy.
It makes me extremely proud to be able to serve you at the VA Maryland healthcare system.
From all of us from the VA Maryland healthcare system, happy Veterans Day.
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 Welcome back to Veterans Health Watch. Joining us now is Dr. Elizabeth Streeton, the director of the Metabolic Bone Program at the Baltimore VA Medical Center and an associate professor of medicine at the University of Maryland School of Medicine. Dr. Streeton, thank you so much for joining us.
Thank you for having me.
We started the show with arthritis and learning about arthritis, the definition of arthritis. Now we want to move on to osteoporosis. So could you define that disease for our viewing audience?
Sure. So osteoporosis is a condition of the bones where the bones become less dense than normal, which makes them weaker and more likely to break. So a person with osteoporosis might have a mild slip and fall on the floor and break a hip.
How is it diagnosed?
So there are two ways osteoporosis can be diagnosed. It can be diagnosed by the occurrence of a hip fracture or spine fracture without any other testing, or of course we prefer to diagnose it before fracture.
Right.
And in that case we use the DEXA, dual energy X-ray absorptiometry, which is kind of like an X-ray test to detect osteoporosis.
Is that considered a bone density test?
That's a bone density test, exactly.
Okay. And who should have a bone density test? Or is this something where you should, maybe when you turn 60 you start having these tests, or more women or men? Who should have a bone density test?
So all women over 65 should have a bone density test, all men over 70, and then a series of other situations such as low sex hormones, so that would include all women after menopause, should consider having a DEXA, men with low testosterone, people who have a series of endocrine conditions that can lead to weak bones, such as long-standing overactive thyroids, excess adrenal gland function, chronic illnesses such as multiple myeloma, liver disease, also people who have a fracture over age 40, even if it seems to be attributed to trauma, such as a slip on the ice. After 40, you should have a DEXA.
After 40, huh?
After 40,
okay.
Yes.
So what role does genetics play in bone health?
So genetics are really important for bone health. At our peak bone strength, which is in the early 20s in women and the late 20s in men, the strength of the bones is about 85% controlled by genes. Just like our height and hair color and things like that are determined by genes, the bone strength at peak is almost completely controlled by genes, and bone loss with aging is highly genetic as well. Up to a third to a half of how quickly we lose bone starting about age 50 is determined by genes.
Are there any preventative measures then to osteoporosis or issues associated with bone density?
Yeah, so environmental factors are important. Getting enough calcium and vitamin D to keep the bone strong is important. Physical activity, trying to avoid too much alcohol, which for women would be more than 2 servings a day, for men more than 3, avoiding smoking, and healthy lifestyle with appropriate exercise.
Healthy lifestyle seems to cover it all.
Yes, yes.
Yeah. So in addition to the genetics, and what other environmental factors can contribute to bad bone health?
So in addition to the genetic things, which of course include age and female sex, although we don't want to forget men, because men do get osteoporosis. About a quarter of men develop osteoporosis in their lifetimes. Smoking, as I mentioned, alcohol, inadequate calcium intake and vitamin D, being inactive, and a whole host of medical conditions such as diabetes, thyroid problems I mentioned, chronic diseases of the liver, the kidneys, all contribute to osteoporosis.
So let's hear about the treatment for osteoporosis. What types of medications or other treatments are available for those with osteoporosis?
So starting with non-prescription medications, calcium is very important, and I always encourage patients to get their calcium in the diet because there's no negative to that, and it's the best absorbed and the best, the body has the best ability to utilize it. And so that would be primarily dairy products or other things such as orange juice that are supplemented, and taking vitamin D because vitamin D we get primarily from the sun, and most people can't get enough of it from the sun. Exercise, weight-bearing exercise, so not swimming. And in terms of medications, unfortunately our medications are getting a lot of negative press lately, but the bottom line is that for people who are at high risk for fracture, the medications that we use reduce the risk of fracture by 50%. So they're very effective, and sometimes we lose sight of the fact of why we're using the medications. They are very effective. In terms of side effects, there are 3 main groups of medications that we use. The first is the bisphosphonates, which most people are aware of. Alendronate, Fosamax, which was the first one that came out in 1995. Risedronate, which is Actonel. Reclast, which is a once-a-year intravenous medication. They all reduce fractures by 50%. So those are the bisphosphonates, and the possible risks of the bisphosphonates include 5% of people have bone pain, which doesn't lead to anything, but generally they have to stop it when they have it. And then there are the rare side effects that people are very afraid of. The first is called osteonecrosis of the jaw, which is after having a tooth pulled, that the tooth socket doesn't heal well. And the risk of that is about 1 in 10,000 for the bisphosphonates. So it's really a pretty rare risk. And the second of the most serious risks is called atypical femur fracture, femur being the thigh bone, where the thigh bone just breaks with no trauma. And the risk of that is 1 in 1,000.
Okay.
But the bottom line is that for people who are at high risk for fracture, for every one of the atypical femur fractures that occurs, we've prevented 100 typical fractures, which are of the hip, where you think of the hip, the typical hip fracture. So the benefits far outweigh the risks for those who are at high risk.
How long is osteoporosis treated?
So it really needs to be individualized. I wanted to just mention the 2 other drugs that we typically use. One is called denosumab, Prolia, and the other one is Forteo, teriparatide. So the treatment duration really needs to be individualized. There is no one size fits all, but typically we start with 3 years of treatment, because for most of the medications, that's what the benefit is based on, 3 years of treatment.
Okay.
And then going forward, we assess the risk of fracture each year with a DEXA and reviewing the history and some lab work to try to individualize.
Dr. Streeton, thank you so much for sharing this great information about osteoporosis. We really appreciate you taking the time to come and talk to us.
My pleasure.
We'll take a short break, but when we return, we'll have information about osteoarthritis, so please stay tuned.
The best thing about long-term care is that we look at our residents, we don't call them patients, they're residents. They don't live in our facility, we work in their home. So the environment, it's a home-like environment. We look at them for what makes them special. What are their preferences? What are their uniqueness?
I am very happy and secure to know that he's somewhere where he's being cared for. I know that he's safe. They're never just sitting idle. They do have trips. They understand different things about them, and they'll explain it to us.
Other than a community living center, we provide rehabilitation services and post-acute services. So not everybody is a nursing home resident, so they may be called patients. We all work together to make sure that we plan and provide the compassionate, safe environment for our veterans.
Welcome back to Veterans Health Watch. Joining us now to talk about osteoarthritis is Dr. Mark Hochberg, the Director of the Medical Care Clinical Center for the VA Maryland Healthcare System. Dr. Hochberg, thank you so much for joining us.
Thank you for asking me. It's my pleasure.
So we want to learn about osteoarthritis. Can you give us a definition of this disease?
Sure. So first of all, let me say that osteoarthritis is the most common form of arthritis that affects adults in the United States. So osteoarthritis can easily be defined as a disease which affects all the tissues of the joint, including the cartilage, which is the material that lines or covers the ends of the bone underneath the cartilage, which the doctors will refer to as called the subchondral bone, and the tissue which connects those parts to form the joint, which is the synovial membrane, the ligaments, and the capsule of the joint. So osteoarthritis causes structural changes in those tissues, and that leads to the symptoms which bring people in to see the doctor or the healthcare practitioner. And those symptoms are pain, aching, and discomfort, which can limit physical activity and physical function.
What is the difference between osteoarthritis and degenerative joint disease?
Okay, so degenerative joint disease is a term which we don't use anymore. So it used to refer to the same condition that we now call osteoarthritis. And it was used at a time when doctors thought that the cause of osteoarthritis was just degeneration of the cartilage, that tissue that covers the ends of the bones in a joint. But over the last 10 to 20 years, we've recognized that osteoarthritis is really a process. And it's a process whereby the body tries to heal damage which has been caused to the joint, so the cartilage or the bone. The body tries to heal that, but as we grow older, we're not able to heal our tissues as well as when we're young. So we have this abnormal or aberrant healing, which leads to osteoarthritis.
That's very
So we don't use the term degenerative joint disease anymore.
It's a very interesting explanation of the disease. So is this just inevitable for aging, osteoarthritis?
So people used to think that it was an inevitable consequence of aging, but that's a myth. So the reality is that while the risk of developing osteoarthritis increases with increasing age, not everybody who gets older develops osteoarthritis. And the reason that osteoarthritis increases with aging is because the cells within the cartilage get older. And as they're older, they don't work as well as when they're younger in terms of producing the chemicals and the proteins that are necessary to heal the cartilage.
And so are there, in addition to aging, are there other risk factors associated with osteoarthritis?
Yes, there are two major modifiable risk factors, which we focus on for what's called primary prevention. And that's being overweight or obese and having a major joint injury, usually defined as something which causes somebody to use a cane or a crutch for 7 days or longer. So overweight leads to the development of osteoarthritis, especially in the knee, probably because of abnormal mechanics that are applied to the joint. So increased body weight leads to increased forces being applied across the knee joint, less so the hip joint, leading to the development of osteoarthritis. And a prior joint injury also alters the mechanics of the joint, leading to osteoarthritis. So those are the two most common modifiable risk factors. There are a number of other risk factors which at the moment are not modifiable, like getting older, being a woman as opposed to being a man, having a family member who has osteoarthritis bad enough to have had a total joint replacement. You can't change those things.
For one who's been diagnosed with osteoarthritis, what role does weight management play in managing the disease?
So weight management plays a very important role. We know that people with osteoarthritis who are overweight have improvement of their symptoms when they lose weight. Losing even 5% of your body weight will produce a clinically important improvement in your pain as well as an improvement in your function. And recent evidence shows that weight loss is associated with slowing the structural progression of osteoarthritis, measured either with X-ray or magnetic resonance images.
Great. So there's always a good reason to manage your weight.
Yes, and that's why at the VA Maryland healthcare system, we routinely recommend that overweight patients with osteoarthritis enter the MOVE program so that they have a combination of nutritional counseling and exercise to help them with weight loss.
And when does a prescriber or a practitioner prescribe medication for osteoarthritis?
So we usually go to medication at the time when a patient is no longer able to cope with their symptoms or control their symptoms by using over-the-counter agents such as acetaminophen, over-the-counter non-steroidal anti-inflammatory drugs, topical agents, and just by weight loss or exercise. So it's at that point we then use prescription medications.
And when does surgery become an option for osteoporosis?
So surgery becomes an option at the time when patients have not had an adequate response to or are intolerant of medical therapy. And medical therapy is really the combination then of physical therapy, non-weight bearing or partial weight bearing with a cane, and then medications taken either orally or injected into the joint.
And what does surgery usually entail?
So the most effective types of surgery for osteoarthritis are total joint replacement, when you actually replace the damaged tissue, the cartilage and the bone, with an artificial joint. And total joint replacement is most successful for hip osteoarthritis, and then second most successful for knee osteoarthritis. And in patients who are in their 60s and 70s who undergo a total joint replacement, a successful procedure, the prosthesis which is put into the body will outlive them.
Oh, wow.
So
that's good to know. And how can a veteran learn more about osteoarthritis or about the treatment options available through the VA Maryland healthcare system?
Okay, so they can learn more through the VA Maryland healthcare system by asking their primary care provider to refer them for consultation, if necessary, to the arthritis clinic. We operate outpatient specialty arthritis clinics, not only at the Baltimore site, but also at Loch Raven and Fort Howard. Sometimes, if they're candidates for total joint replacement, they should be referred to orthopedic surgery. And then they can go outside the VA system and contact the Arthritis Foundation, which is the largest nonprofit organization which provides information for patients with arthritis. They can call the Arthritis Foundation Maryland chapter and be asked to send informational pamphlets, or they can go online to the Arthritis Foundation website at www.arthritis.org.
Well, thank you so much, Dr. Hochberg. We really enjoyed you sharing so much information with us about osteoarthritis.
It's my pleasure, and I'm happy to come back in the future if you'd like.
We like. Well, that wraps up this edition of Veterans Health Watch. If you have questions about today's show or would like to make suggestions for future topics, please call us at 1-800-463-6295, extension 7101, or you can join us on our website at maryland.va.gov. We look forward to hearing from you. And remember, if you are a veteran or you know a veteran who is not using the VA Maryland healthcare system, please contact us. You can visit one of our medical centers, our website, or join us on Facebook or Twitter. We look forward to serving you.
A lot of women veterans don't realize that the VA is here to take care of them. They served and they deserve the best health care that there is. The Women Veterans Program has been redesigned to meet the needs of the women veterans.
Female veterans receive just as good a care as men because they're focused more on us now.
We want them to come here, we want them to feel welcomed, and we want them to know that we are capable and willing to take care of them.